go ahead and get started. Good morning, everyone. My name is Darshan Mehta. I'm the Medical and Education Director for the Osher Center for Integrative Health here at Brigham Women's Hospital and Harvard Medical School, and it's really my joy to invite you all to our August grand rounds this morning. We really have a wonderful treat presentation, and just before we get started and introduce our speaker, let me just share a few just introductory slides. One second here. Okay, so today I'll introduce Dr. Sofia Matta in just a moment. For everyone, if you would like a CME credit uh, for live participation, please email us at hmsoshercenter@bwh.harvard.edu. Please include your full name, your degree, and your institution. This is a Zoom webinar, so please remain on mute until prompted for Q&A and type questions into the Q&A box. We will then curate the questions and present them at the end of towards the end of the presentation. This meeting is being recorded and will be posted on the oshercenter.org website. And just as a preview to our next grand rounds, so that those of you who are here know, our next grand rounds will be on Tuesday, September 2nd. It will be integrative oncology supporting lifestyle change, a new clinical model as a standard of care. This will be done by Dr. Gabrielle Lopez from MD Anderson. And then just as a reminder, our registration will open in November 2025 for our Tai Chi and Qigong conference, The Science of Tai Chi and Qigong as Whole Person Health, Deepening Our Physiological Understanding of Mind-Body Integration. This will be held on April 30th to May 1st, and we really expect a wonderful turnout here. It's building upon the success of our last conference. So with that, it's really my joy to introduce my colleague, Dr. Sofia Matta, from the home base. She's Senior Director of Medical Services at MGH, Home Base National Center of Excellence. Dr. Matta received her medical degree from Weill Cornell Medical College, and she completed her residency at New York Presbyterian Hospital Payne Whitney Clinic. She's a diplomate in psychiatry, consultation liaison psychiatry, brain injury medicine, and addiction medicine. She's also a fellow of the American Psychiatric Association and fellow of the American Society of Addiction Medicine. Dr. Matta became a medical acupuncturist prior to working for the Department of Defense, Defense Health Agency with the U.S. Army and U.S. Navy. She received her Commander's Award for Civilian Service from the Department of Army. She obtained her board certification in brain injury medicine while working at the National Intrepid Center of Excellence, Intrepid Spirit of Center at Naval Hospital Camp Pendleton. She then served as the Consul Chief of Consultation Liaison Psychiatry at the VA Greater Los Angeles Healthcare System. While there, she was awarded the Spark Seed Spread Innovation Investment and Accelerated Program Innovation from the VHA Innovators Network for the VA Mental Health Mobilization, Engagement, Navigation, and Delivery, VA MEND, Proactive Consult Model. She has presented research from the VA on social determinants of mental health in veterans, including age, race, ethnicity, income, and homelessness. So she's currently an instructor of psychiatry here at Harvard Medical School and really has taken a lead in this space of brain injury medicine, PTSD, and proactive consultation liaison psychiatry. Her areas of interest are military and veteran healthcare, PTSD, brain injury pain, and the interface between medicine, psychiatry, and neurology, and has really been a champion in innovating particularly the intensive clinical program, which has been one of the jewels of the home base program here at MGH. So with that, I'm going to turn it over to Dr. Matta.
Thank you, Darshan, for such a wonderful introduction. So I'm going to share my screen. And if you could just let me know when you are able to see it.
Yeah, we are good.
And are you seeing just the full slide?
Yes.
Okay. No notes or anything like that?
Correct. Yeah.
Okay, awesome. Just checking. Okay, wonderful. So I'm going to be talking today about HealthSpan as well as advancing mind-body interventions for warrior well-being. So I do have a couple of disclosures, mostly for academic work, and also we are in the process of analyzing the data from the first 3 months of the intensive clinical program acupuncture implementation. So I won't be discussing any of the data results or preliminary analysis from that work. And there will not be any significant overlap in the content of this presentation and the forthcoming findings. So stay tuned for the next iteration of this where I can actually reveal the findings. So these are the lofty goals that I'm hoping to get through during today's presentation. Describe the historical origins and foundation principles of acupuncture, including traditional theories, modern mechanisms of action, and identifying key components of medical and military acupuncture, including battlefield acupuncture and the home-based mission-ready acupuncture protocol, and discuss how integrative health interventions such as acupuncture and other interventions like mind-body wellness here at the home-based intensive clinical program and comprehensive brain health and trauma or combat program have been integrated. And then how these innovations in brain health, trauma, and the concept of HealthSpan optimization can enhance resiliency and recovery, improving the lifespan and the quality of life, not only here with military and veteran populations, but also within civilian populations as well. So turning to acupuncture's origins, acupuncture actually dates back to about 5,000 years ago during Neolithic times, when people used sharp stones called bianchi to relieve pain. This was the earliest groundwork for what later became acupuncture. During the Han Dynasty, the Huangdi Neijing introduced meridians, the concept of qi and acupressure and acupuncture points, and this shaped traditional Chinese medicine. Later texts from the 3rd and 7th century refined these ideas, and by the Song Dynasty in the 11th century, bronze models were created with engraved meridians and points, and these were actually used during training and during medical exams. I found this story really quite compelling. So Otzi the Iceman, actually, there's an evidence that this is an ancient medicine that predates a lot of the modern findings that we oftentimes discuss. So Otzi lived about 5,300 years ago and was found frozen in the Alps in 1991, remarkably well preserved. His body had 61 tattoos, many on joints and lower back, areas associated with pain relief and acupuncture points. These tattoos were made by cutting the skin and applying charcoal, likely for therapeutic purposes. And new imaging has revealed hidden chest tattoos near points that are tied to gut health. These findings suggest his community had an early medical system, possibly using acupuncture 2,000 years before it was really well known in Asia. The world's oldest steel acupuncture needles were discovered about 2,000 years ago in the tomb of the Marquis of Haihun in Western Han Dynasty, which is about 200 BC to about 25 AD. They were found inside a jade tube with a gilded lacquer box near the remains of a former emperor. 5 needle fragments were recovered, very delicate and corroded, but carefully preserved. Advanced analysis showed that they were made from an ancient frying steelmaking technique, producing needles that were 0.3 to 0.5 millimeters thick. So these are very thin needles, very similar to modern acupuncture needles. And a nearby wooden tag read 9 needles complete, confirming their medical use as described in early Chinese texts. Some of the oldest records we have about acupuncture and the classical acupuncture with the systematic classic of acupuncture and moxibustion dates to about 259 of the Common Era. Written by Wang Fu Mi, this was the first major text to organize acupuncture theory and practice in a clear clinical system. Still used today, it helped formalize treatment methods, point locations, and indications. And on the right is a Ming Dynasty acupuncture chart dating back to about the 1300s to the 1600s. And it beautifully illustrated meridians and points used for medical education and reference. And this is actually preserved within the National Library of France, reflecting both the scientific and artistic legacy of traditional Chinese medicine. As I said earlier, early acupuncture educational tools were found dating back to the 11th century in an anatomic model. On the left, you see a drawing that's centuries old from a Shanghai museum, showing and depicting students training on a larger-than-life model that was filled with water. If they hit the correct acupuncture point that was plugged with wax, a tiny fountain would spray, producing instant feedback that they had needled the correct point. The image on the right is actually a bronze anatomical model that dates back to 1027 AD and is the oldest known acupuncture teaching tool in China. It was used again similarly to the drawing that's in the left. And both images reflect the sophistication of early medical education and training of traditional Chinese medicine, blending science, art, and precision. Turning more to the concept of qi or vital energy, qi is a vital force or energy that flows through the body along meridians in traditional Chinese medicine. The character itself is actually made of two parts. The top part represents steam or vapor, something dynamic and flowing, whereas the bottom part represents rice, symbolizing nourishment and material substance. Together, the character reflects the idea that energy generated by the transformation and nourishment into breath and movement, the fusion of the physical and the energetic. Qi is often seen as essential for health, vitality, and balance, and acupuncture aims to restore smooth flow through the body. This is an actual pictorial representation of the same concept and what animates the physical. Qi is also found in nature, the breath of the earth. In traditional thought, qi is not just what's inside of us, but it's in the world around us. This landscape reflects that qi is in the flowing mist, the rising sun, the moving air, and living energy, and that the morning light warms and wakens the land just as qi energizes the body and spirit. Looking at the evolution of acupuncture needles, on the left upper, you see a bone needle and also from stone to bone and to steel. Stone implements like bianchi date back to Neolithic China, bone and bronze needles around the same time. And in the classical text that we discussed, illustrated the 9 needles that are there and had different shapes for different therapeutic indications. Steel needles are now the standard, thin, flexible, almost filament-like, and minimally invasive. If you look on the picture on the right, you see a comparison between a matchstick, a hypodermic needle, and all the way on the right, you see the battlefield acupuncture ASP needles, which look like little tiny darts or earring studs, and they go in the ear and stay in for 3 to 5 days. If you further look at the discussion of the evolution of acupuncture, originally it was practiced mostly in China, and then now it's spread to Japan, Korea, France, and the ASP battlefield acupuncture, again, are French needles. And this developed over several thousand years and involves concepts with no equal in Western medicine. And the modern concept or theories can include that the acupuncture actually helps the body release its own natural painkillers, which can produce pain, or reduce pain, improve mood, and support the body's natural healing process. Turning toward more Western theories, manual acupuncture is thought to work through needle manipulation, and movement stimulates the surrounding tissues, activating mechanical sensitive ion channels, triggering mast cell degranulation, fibroblast activation, and macrophage polarization, releasing and causing changes in ATP, histamine, and substance P, which modulate pain receptors and enhance peripheral analgesia. It leads to stimulation within the central nervous system and leads to the release of GABA, 5-HT or serotonin, norepinephrine, and opioid peptides that are naturally occurring endorphins, leading to central analgesia. It also impacts the hypothalamic pituitary adrenal or HPA axis, lowering cyclooxygenase 2, prostaglandin E2, and inflammatory cytokines while boosting IL-10, dopamine, and nitrous oxide, overall leading to a relief of pain, reducing inflammation, and restores movement function. Turning to functional imaging of acupuncture, we see that fMRI studies show that acupuncture, compared to just touching, leads to a larger integration of the activation of the sensor-motor network involving the insula, thalamus, and the anterior cingulate cortex. Simultaneously, it deactivates the limbic, paralimbic, and neocortical network. So if you think of the limbic, paralimbic, that might be emotion regulation as well. Compared to tactile stimulation, this evokes a stronger, more distinct hemodynamic responses, and these patterns reflect sensory, cognitive, and affective dimensions of pain, with implication for enhanced treatment when paired with contextual, emotional, or sociocultural factors. Turning to additional modern acupuncture theories and immune regulation, we see that acupuncture generates mechanical and thermal stimuli at the acupoints, activating somatosensory fibers that signal the central nervous system, leading to triggering of anti-inflammatory pathways, the involvement of the vagus and adrenal system, which again is involved in stress and post-traumatic stress, as well as pain. The spinal sympathetic pathway, which again is involved in pain, as well as the brain-gut pathway involved in irritable bowel syndrome and the microbiome. And it also modulates macrophage activity and cytokine release to reduce inflammation while supporting immune balance by regulating T cell subsets and natural killer cell activity. Turning more to the challenges that it can be found within acupuncture, there are several. Number one, sham acupuncture, which could involve non-insertion or superficial needling at what are considered non-acupuncture points. They often produce physiological effects, making it not truly inert, which challenges the control group validity. Also, minimal acupuncture and acupressure can still stimulate mechanosensitive pathways, blurring the line between placebo and active intervention. Also, traditional Chinese medicine is individualized and dynamic, considering constitution, pattern diagnosis, and time, elements that are hard to standardize within randomized controlled trials. And again, as I've mentioned, balance, the flow of qi, whole person, and well-being are not easily captured by traditional quantitative measures alone. These limitations may have led to the mixed or negative randomized controlled trial results that we see, despite strong clinical and historical evidence of efficacy. And I argued, actually, when I was building this program, that a mixed methods or qualitative approach might be better suited to understand patient experiences, the therapeutic context, and the mechanism of benefit beyond reductionist models. So how did the United States and Western medicine get introduced to acupuncture? So acupuncture entered the American spotlight way back in 1971 when the New York Times journalist James Reston accompanied President Nixon's historic visit to China. While he was in Beijing, Reston developed appendicitis and underwent emergency surgery at the anti-imperialist hospital. After the operation, Chinese doctors used acupuncture for post-operative pain relief, and Reston was so struck by the effect that rather than fully discussing President Nixon's visit to China, he actually wrote a front-page article titled, "Now About My Operation in Peking," introducing millions of Americans to acupuncture for the first time. Turning to another story that actually intersects with the development of the mission-ready acupuncture protocol, acupuncture in America has its healing roots within activism and resistance. In the 1970s, acupuncture was embraced by activist-led communities, particularly at Lincoln Hospital Detox Center in South Bronx. At Lincoln Detox, the activists were not just offering a treatment, they were redefining recovery, trading one set of needles for another, from needles of substance use to needles for healing. Community acupuncture really became a tool for recovery, resilience, and dignity. Community acupuncture wasn't private, it was done in groups, in waiting rooms, shoulder to shoulder. This demedicalization of care made healing visible, communal, and non-hierarchical. It reflected the belief that healing is a collective act, not just an individual one, and allowed more people to receive care at once, especially in under-resourced and overburdened systems. The Young Lords, Puerto Rican National Group, and Black Panthers helped establish the clinic to address addiction and systemic neglect in marginalized communities. And the center became the first in the US to offer acupuncture to treat heroin withdrawal, offering a non-pharmacological solution. Dr. Mutulu Shakur, the stepfather of Tupac, was a key figure in integrating auricular acupuncture into detox protocols, later co-developing the NADA protocol with Dr. Michael Smith. Turning to Colonel Richard Niemsow, he was a pioneer in military acupuncture and was the first full-time physician acupuncturist in the US military. He developed battlefield acupuncture using ear points to rapidly relieve pain in both combat and clinical settings. He designed battlefield acupuncture, or BFA, to be fast, field expedient, and effective, especially for acute and complex pain. And he helped transform acupuncture from an alternative therapy into mainstream integrative tool within the Department of Defense and the VA. His work laid the foundation for military-wide training, research, and adoption of acupuncture protocols. So back in October of 2024, here at home base, we trained about 10 US psychiatrists and providers, both physical medicine and rehabilitation docs, brain injury medicine docs, and psychiatry clinicians. In this past May, we also welcomed about 10 Ukrainian Special Forces psychiatrists, fellows, and frontline personnel. And the training focused on auricular acupuncture for pain, both in civilian and combat settings. John Howard here is actually shown teaching Kalo how to give me acupuncture. And John Howard himself is a US Air Force veteran who deployed and worked closely with Colonel Niemsow for many years. And he's trained providers across military branches and internationally. In addition to battlefield acupuncture, we do also include the Helms Auricular Trauma Protocol, which is a specific approach for trauma-related symptoms. And each of the actually six specific auricular acupuncture points are associated with the limbic system, autonomic regulation, emotional processing, your overall spirit, and also to help bring balance to qi. It's something that's scalable and efficient, evidence-informed, and can be integrated into austere locations as well as within group settings and field hospitals. Turning more to the mission-ready acupuncture protocol. So my background of how I got here, I'll just talk briefly, just looking at the time. As some of you may know, I was actually in New York on 9/11. I saw it happen in real life. I'm pretty sure that's why I went into military medicine. And then after Hurricane Katrina, I moved to back home to New Orleans and was working on an inpatient active duty rehab, and then also providing acupuncture service and detox within an outpatient clinic. And I wanted to become an acupuncturist actually to provide relief of pain in those who had been prescribed opioids by their providers and ended up, developing opioid use disorders. And that's how I met Dr. Joe Helms, Colonel Kaufman, and some other real luminaries within the field of medical acupuncture. So I wanted to call it the Mission Ready Acupuncture Protocol to really sort of highlight that this doesn't have to be a treatment. You do not have to have a diagnosis to have a benefit from acupuncture. It really is about wellness and resilience. And within the intensive clinical program, we offer up to 4 group auricular acupuncture sessions over the 2 weeks. And in addition to acupuncture needles, you can use acupressure magnets or ear seeds. And based on an individual personalized interview with the patient where we ask about pain levels, stress levels, cravings, sleep, and where their actual pain problems are, I come up with a treatment plan for that day and for further sessions, looking at what the common sort of themes are and what treatment would work best. So we do use battlefield acupuncture and the Helms auricular trauma protocol, as well as the Matta protocol for cravings. And within the combat program, we have 1 session, and it can be acupuncture with or without electrical stimulation, which is kind of like a TINS unit. And then any of the other ones as well, too. We know that according to the American Academy of Medical Acupuncture, acupuncture encourages the body to promote natural healing and improve function, promoting health, well-being, and prevention of illness. And the World Health Organization has recognized the benefits of acupuncture for low back pain, migraine and tension headaches, neuropathy or nerve pain, stress, and emotional disorders. So looking at the scope of the problem, there's this study that looked at pain levels and claims over an 11-year period from 2010 to 2022 or 2021 within active duty service members, looking at musculoskeletal injuries and prevalence. And what they found is significant amount of lower extremity, spine and back, upper extremity, and head and neck pain. And they looked at the costs. And in fiscal year 21, the military health system incurred $132 million in private sector costs for lower extremity musculoskeletal injuries, $100 million, for spine and for upper extremity, and $43 million for head and neck. Turning to the prevalence, lower extremity musculoskeletal injuries lead in prevalence with 24 to 29%. Followed by spine and back, 17 to 20%, and upper extremity, about 15%, but a persistent burden across all services and years. Turning to special operations forces. So this study had colleagues from Naval Special Warfare Group 2 and Naval Special Warfare. And the bottom line up front is that musculoskeletal patterns with NSW personnel, including SEAL, those within qualified training, so BUDS training, the combatant crew members, and those in training, describe musculoskeletal incidents and injury patterns across these groups during a medical chart review of about 1,000 participants. And what they found is that the top injury types similarly are pain, spasm, aches, tendonitis, and fracture. Within the SEAL population, shoulder or upper extremity was most common. Within the training, foot and toes, and within the combatant command, lumbo-pelvic spine, and those in combat command training, lower extremity or knee, and that they're very prevalent and very viral. Many of them are preventable, supporting the need for targeted intervention and prevention. Looking at overall severe pain in veterans, about 10% have say their pain is severe, and almost 2/3 of veterans note that they have pain. And within the past 3 months, over 50% notice that they've had pain problems. Similarly to the active duty, back pain is extremely common, about 1/3. Joint pain is seen in about 44%, and severe pain was significantly higher in veterans with back pain, jaw pain. So I constantly ask about TMJ or jaw symptoms, and severe headaches and migraines, as well as neck pain. So a group of us here at Home Base wrote an article on multimodal pain control for acute and chronic pain presentations. And really the way that I like to present this is to discuss the non-pharmacologic interventions that can be done on top before you even get to medication interventions on the bottom. And what you can see is that there are numerous types of pain, whether that's arthritis, fibromyalgia, migraine, or other types of headaches, and musculoskeletal pain. And many different interventions can help with all of these, whether it's ice or cryotherapy, heat, sauna, neuromodulation, which could be non-invasive vagus nerve stimulation, alpha stim, or others, photobiomodulation or red light. And then if you look at acupuncture, if you look at the number of different types of pain, there is evidence in numerous types of pain that acupuncture can be helpful. So many people know about the Defense and Veteran Pain Rating Scale, but it's essentially a 0 to 10 Likert scale with different anchor points based on how the pain is impacting you, from mild, moderate, or severe. But what oftentimes doesn't get discussed is the DVPRS pain supplemental questions, which is the pain interference questions in terms of how it impacts your activity, how it's interfered with your sleep, your mood, and stress levels. So if you look at overall the lifespan of service members and active duty service members and special operations forces, you can think of things on a continuum of exposures. And allostatic load is the health impact that looks at the long-term effects of chronic stress on the body and mind, not just the acute stress responses. And the term allostatic load was coined by Bruce McGowan, a pioneer in neuroendocrinology, and noted that it represents how stress systems like the HPA axis and the immune system can become dysregulated over time. And it's a useful concept in bringing forth biological, psychological, and social models of disease. And he noted 4 patterns of dysregulation, including overactive or constant fight or flight arousal, an inadequate response, meaning weak recovery mechanisms and a failure for the system to shut off, as well as poor timing, where you can have a stress response that's triggered at the wrong times. And allostatic load challenges can lead to a broad range of issues, whether that's high blood pressure, metabolic and immune dysfunction, anxiety, cognitive decline, emotional reactivity, and that mindful stress regulation, including meditation, connection, and different types of therapy, including mind-body wellness and acupuncture, can help reverse or buffer these effects, which are key in both clinical and preventive settings. And then this also translates into the HealthSpan roadmap. So this is actually based off of work by Dr. Ross Safant and the NFL longitudinal player study, looking at the impact of professional football on those who are engaged, the elite athletes, the 1% of the 1%. And he noticed that their lifespan was decreased by about 10 years. And so at Home Base, we decided to convert this into a military and veteran population. And on the top, you see, without HealthSpan interventions, you can see chronic stress, physical and mental trauma, brain injury, repetitive exposure to low-level blast or breaching, jumping out of planes, the G-forces of the combatant crew, fast boats, alcohol and substance use, exposure to toxins, which can lead to increased risk for cancer and infections, and over time can lead to decreased health and life expectancy. So it's not just the shortened lifespan, it's also the quality of life that's lived. And with HealthSpan intervention, whether that includes, focusing on sleep and pain, the adoption of acupuncture techniques, stress management, and all of the components of our programming here, what we hope is that this will lead to an increased health and lifespan so that people not only live longer, but that they feel better. So I did want to stop and pause. And so in the past 2 weeks, knowing that I wasn't going to be able to present any of the information from the first 3 months of acupuncture, I decided to ask everyone in the group if they wanted to give anonymous feedback. So this was ChatGPT put this together. So my apologies if there are problems with spelling and or the way it looks. But these are direct quotes from several of the people who came through the program. And if you notice, it's not just one thing or the other. Oftentimes they notice improvement in sleep and energy and pain, or pain and anxiety. So it's not just one thing. And on the right lower corner, you notice that the person did not respond to the battlefield acupuncture needles, those little stud ones, but he did actually have a significant response to the regular filament type needles. And so again, when I'm able to have more than one session with an intensive clinical program, I can change the treatment based on response or lack of response. Overall, these are the findings that have been seen: reduced pain after treatment, improved sleep, lower stress, and restored energy and clarity. And so the words, I think, speak for themselves, regardless of what the final study results show. It's more than pain relief, it's a pathway to recovery. So with that, I think I'm done.
Thank you, Dr. Matta, for, again, a beautiful presentation. I'm having a little bit of trouble with my video just for a moment, but I just wanted to go ahead and start some of the questions. One of the first questions to just curious from your perspective as the battlefield acupuncture protocols have become more popular, what is some of the controversies or resistance you may have faced when vis-a-vis sort of conventional acupuncture and both medical acupuncturists as well as sort of traditional acupuncturists that have been trained, and in terms of how they view these protocols?
Oh, that's a great question. So both at Camp Pendleton and at Vordrum, I worked alongside, more at Camp Pendleton, they had more resources, but I worked alongside traditional licensed acupuncturists as well as medical acupuncturists. And I think the biggest challenge is access to care and the ability for whether it's licensed acupuncturists or medical acupuncturists to actually provide treatment to as many people as possible, so that as much resources as you have, there just really are typically not enough to go around. As you alluded to, the training for an acupuncturist is really 4 years of traditional Chinese medicine, whereas for medical acupuncture, it's typically a 6-month course that involves over 300 hours of training, both in person and through video distance learning as well too. So they're not necessarily the same. Physicians do benefit from being able to have, anatomy and physiology, being able to do, dissections and or prosections, or the level of training that they have, so that there is a rationale for why physicians can, do less training than licensed acupuncturists. But I work extremely well with licensed acupuncturists as well too, knowing that they have a much more evolved concept and ability to practice than we do. But I think it's very complementary. With specific questions about battlefield acupuncture. So again, it was born out of necessity and also for it to be field expedient. So within the active duty military and within federal land, whether that's a VA, or even at the USS Constitution, they can do battlefield acupuncture training through people like John Howard or others. And it's essentially 4 hours of didactics and then 4 hours of practice. And on federal land, you can receive an acupuncture certificate. So training does not have to be limited to just physicians. Nurses, even within Naval Special Warfare Group 2, they had PAs and corpsmen, physical therapists who were trained in acupuncture, both medical acupuncture and battlefield acupuncture, but really where it can be amplified most is that it doesn't require, the same formal level of treatment. There are some people who say that that's not necessarily the same thing. You can also see patients who are reluctant to getting the battlefield needles placed. Meanwhile, they've got tattoos all over their body and or have done dry needling, which is, obviously a lot more intensive of an intervention. So, I think that oftentimes it's just lack of knowledge, and the cohort group actually provides people with the ability to see different types of acupuncture being practiced amongst their peers. And also it decreases sort of the overall anxiety and stress of having these treatments. I think I've answered your question somewhat.
Okay. No, that's very, very, that actually is very helpful. I think as a follow-up, also curious to understand what are some of the challenges or stigma that you may have faced amongst veterans or active duty service members around receiving acupuncture? Are there sort of biases that come into play or that you have to address in a regular way, or in terms of the explanatory model of what is happening? What are some of the challenges that you may have encountered?
Sure. So as what I didn't mention is that with medical acupuncture and the MRAP protocol here at home base, I do an introductory lecture or discussion with each of the cohorts. And, I've had acupuncture, I've had an ankle injury, and so I discuss that and I have people sort of raise their hands again, knowing it's a group or a community that's doing the acupuncture. So when I do that, what I notice is that actually it's a lot more integrated within active duty service members and veterans than it used to be. So I think it really is becoming more mainstream. And if they haven't had that, they have had dry needling or cupping or scraping as well. So I think that there are always people who haven't had it, and there can also be anxiety or a concern about well, what does the treatment do? How long does it last? And it varies for everyone. So, but that being said, being able to provide acupuncture for essentially every person who comes through the intensive clinical program and combat program, it's very humbling to see the responses that the majority of them have.
In terms of the people you've trained at a home base around the battlefield, can you speak to a little bit about the varieties of professionals that have been trained and what their experience has been in deploying the battlefield acupuncture protocol?
Sure. So I think a lot of this has to be context specific. So because home base isn't a federal land, we could really only train physicians because nurse practitioners do not have an ability for that to fall under their license. Also, other people, whether they're non-medical, and so it has to be within the state's scope of practice. So the positive side to that, though, is that any physicians can be trained in acupuncture because within Massachusetts, physicians can be licensed as acupuncturists as long as, or can practice acupuncture as long as they've received appropriate training. So we had physical medicine and rehabilitation doctors from Spalding and from home base, also residents who were in attendance. But the Ukrainian folks who came through were not all physicians, and we benefited from the fact that obviously in Ukraine we can train them and provide them with the training that they can then deploy to the front lines, which it really is than truly battlefield acupuncture in the real sense of the word.
Are there any sort of adverse outcomes that have been reported in the military acupuncture protocols, or even in the battlefield acupuncture protocols that people should be aware of as a
That's a great question. I had to decide what slides to include. So the common reactions are obviously that people feel an improvement in anxiety and pain, and also feel like they're thinking more clearly. The most common side effects may be with the filament needles, when you take it out, there might be like a speck or a drop of blood. In Chinese medicine, that's considered bad blood, and you're supposed to squeeze out as much of it as you can. Also, if you think of the ear, oftentimes they're extremely well vascular territories, so you can get small amounts of bruising. We did have one person who developed a mild ear infection that had to get treated with antibiotics, but that's extremely rare. And I think that's happened once during my entire career.
So one of the things just was we're just also thinking is in terms of the bigger vision of as how integrative approaches are incorporated. Both obviously you've had the experience of seeing some of these applications happen on the VA side, as well as now in a sort of a private-public partnership. And curious as to what your thoughts are of how, as you're looking at this very sort of difficult to treat population. What are some of the other approaches that are being explored both in synergy with the battlefield acupuncture protocol as well as maybe as separate from as well?
Sure, great question. And I also just realized I didn't answer one of the other questions. So within those who were trained in battlefield acupuncture, we are still in the process of getting them credentialed within the department, even though according to the Massachusetts license, they can practice. So the behind the scenes is that this actually took a year to set up between standard operating protocols and also just making sure everything was in place. And just repeat your question again. Sorry about that, because I just realized I hadn't answered that one question.
Just thinking about also what are the other as we look at both in the VA context that you've had sort of journeys with, as well as in this private-public partnership through home base, what are some of the integrative approaches that you might be looking at that maybe used both in synergy with acupuncture protocols, but also maybe even separate from?
A great question. Well, within home base, we do offer mindfulness and yoga. Mind-body medicine is extremely important here, and we also use exercise and integrate that along with breathing techniques, the Vincent Henry Smart program as well too. And within the VA, there's an entire pain protocol, and just like the VA, we recommend that there is integration of cognitive behavioral therapy and other modalities in addition to pain. Where I think I see the most hope for future developments is within neuromodulation, as well as photobiomodulation and other interventions, whether that's heat therapy or whether that's through sauna or cryotherapy as well too.
Oh, wonderful. In some of the one of the comments that came up in the Q&A was that is there a rationale or is there evidence that you've seen for acupuncture working in individuals that have known sort of physical attribution to sort of the cause of their pain? So, for example, they may have herniated disc, or they may have had a significant injury of one sort or another, physical injury from the trauma associated with being in the military. So how do you explain that this actually can work even in the context of having had sort of a physical explanation?
Yeah, that's a really great question, and one I get very often. So I often liken chronic pain to the robocalls or spam calls that you get. Oftentimes, the brain is sending out these signals even after something is healed. So it's essentially the wrong number, or it's a spam call, and you have to kind of figure out how can you get your body to sort of hang up and get it so it doesn't dial back. So I think that that's a useful analogy. And I've treated people with significant decreased range of motion, whether that's from the shoulder or neck. And when you see people who can only raise their arm this high, and then within a few minutes, they're like, yeah, I can do this all the way now and I have no pain. Where they oftentimes talk about the structural changes that are, with their rotator cuff or the crunchiness that they have in their neck. A notable uh, person who attended our intensive clinical program was someone from Special Operations Forces who had a spinal cord uh, problem with a spastic scissoring gait. And he noticed that when he was walking, he said before his first acupuncture needle, when he used to walk, his whole entire visual field would be moving. So it was very challenging for him to walk because it also induced dizziness and this feeling that he was unsteady. So much so that when I inserted the first needle, I was walking with him and I was concerned that he was going to fall. And what he noticed after the first battlefield acupuncture needle was that the vision stabilized completely, which is really remarkable. And then his pain went from an 8 down to a 5. And then with additional needles, it went down to a 3. And with additional treatments, it went down to a 2. And the way that he walked was completely different from day one to the end of the intensive clinical program. And I say that just to say that acupuncture really is something that works with healing, regardless of what the underlying structural changes can be. Obviously, if you need a surgery, it's not going to necessarily fix that, but it could be possible that you can see an improvement despite what the images say or what your limitations are.
And in terms of I just want to think of again the vision for this, how you envision these protocols being incorporated into the home-based clinical program and other outpatient. What is the bigger vision that you see for this service being offered?
Well, so right now we're waiting for additional providers to help out with the number of people to provide acupuncture within intensive clinical program and also within the combat program. So if you think of it, I am an N of one right now providing the service. So if I'm out, then the acupuncture doesn't happen. So making sure that there are additional people who can provide this service here within home base. And I'm frequently looking for other people who can be trained in battlefield acupuncture. I have John Howard, I consider a friend and a colleague as well too, and his wife, Sarah. The goal for next visions, I think specifically within home base, would be to look at randomized controlled trials and look at different biomarkers, whether that's the cytokines or looking at biomarkers, both physical and also whether that's the use of um, wearable technology to track heart rate variability, resting heart rate, and additional uh, biological mechanisms of it, and looking at randomized controlled trials again, even with the challenges associated with that.
Wonderful. Um, and I guess if for someone to be trained um, in this approach, there are only are there specific spaces that people can be trained beside? I know you've offered it through home base, but are there other spaces that people have to, if they wanted to be trained in this protocol, they could get trained?
Well, they can definitely reach out to me, and I'm happy to connect them with John
Okay.
Howard. And we can also work on, potential future offerings here at home base.
Great. Wonderful.
And I noticed a question in the chat, and if you don't mind, if I can answer
Sure.
it. So the question is, how does a practitioner of battlefield acupuncture locate a specific point for a particular patient given anatomical variation? So that's a great question, Dr. Rouse. So one of the slides that I didn't include was the anatomy of the ear itself. So if you also look at the actual acupuncture points, a majority of them are really about the size of an eraser. So it's not necessary to have that specific of a point, but usually as long as it's within the specific region. In addition, there are additional tools that can help. One of them, it's called a pointer finder, and it kind of looks like a stud finder, and it looks at increase in conductance or decrease in resistance, and that can actually help pinpoint the specific spot. And it also has blind diagnostic accuracy of up to 86%, meaning that if you look at a certain area and it ends up being an endocrine spot, I've asked people this question, do you have any endocrine problems? And they said, yes, I have, hypothyroidism or those sorts of things. And I think that sort of speaks to it. And acupuncture points, so if you were to look at the actual cross section of it, each individual acupuncture point is an area where there is increased innervation, increased vasculature, and also there's a difference in the variance between the ion and charge of the actual needle and the tissue surrounding it. And when you manipulate it, that actually, again, sort of charges the actual acupuncture point.
Well, Dr. Matta, we wanted to again sincerely thank you for this wonderful presentation. We look forward to having you and the research team come back to present the outcomes of the protocol. It's certainly very unique. You're in a very unique space, and I think what you're doing is really truly groundbreaking. So thank you again for sharing this sort of background and preview and what to look forward to as we continue such important work. So with that, let me just turn it over. If I could share my slides one more time. Let me share. And so again, if you would like credit for today's presentation, please email us at hmsoshercenter@bwh.harvard.edu. And again, as a reminder, we will have our next presentation on Tuesday, September 2nd at 8 a.m. It was a Zoom presentation, Integrative Oncology Supporting Lifestyle Change and New Clinical Model as a Standard of Care by Dr. Gabriel Lopez, who is the Center Medical Director for the MD Anderson Cancer Center Integrative Medicine Center. As a reminder, just to be on the lookout for our wonderful conference, and the registration will be opening soon. There's already been a call for submissions for symposia, panel discussion, scientific abstracts on the science of Tai Chi and Qigong as whole person health, deepening our physiological understanding of mind-body integration. Please do submit. And again, we had a wonderful turnout at our previous conference, and really building on that momentum for this upcoming conference. And then again, a lot of this work is really based on such wonderful benefactors, and again, this supports the Grand Rounds, the Network Forum, the Tai Chi Qigong Conference, our work that we do at the clinic, as well as our research program, including mind, body, movement, planetary health, and nutrition supplements. So with that, thank you everyone for being here. Thank you, Dr. Matta, again for a wonderful presentation, and we look forward to seeing you next month on Tuesday, September 2nd. So until then, be well, everyone, and we'll see you soon.